Hello students, let us learn today about the gross anatomy of the pleura and the lungs. The gross anatomy of the pleura and the lung is a very fascinating topic because it is clinically a very relevant topic. The objectives for learning gross anatomy of pleura and the lungs are: we can understand the differences between the surface markings of the pleura and the lungs. We are able to identify the areas on the surface of the chest where breath sounds can be auscultated for specific lobes of each lung. And we also understand the clinical importance through the gross anatomy. We can understand the clinical importance of the bronchopulmonary segments. Now, when I think of the pleura, to my mind, I start wondering what could go wrong with the pleura so that a patient will come complaints pertaining to the pleura. So, to understand this, we must know one clinico-anatomical problem so that after learning the gross anatomy of the pleura, we will be able to solve this clinico-anatomical problem. So, let us take a look at a simple clinico-anatomical problem pertaining to pleura. Now, imagine a young man who comes to a doctor with a complaint of chest pain, let us say on the right side, and on examination, the doctor finds that there is a dull note on percussion in the lower part of the right side of the chest. The doctor orders an X-ray, a plain X-ray of the chest, and he finds that there is a fluid in the lower part of the pleural cavity on the right side. You have to identify this clinical condition. Now, only if we know the gross anatomy, we will be able to identify the clinical condition, as well as we will be able to give the answers to the questions on pleura. Now, first thing to understand is that pleura is a serous membrane inside the thoracic cavity. It forms a separate pleural sac for each lung, right as well as the left. And this pleural sac is bounded by a visceral pleura and a parietal pleura. The visceral pleura is known as the pulmonary pleura since it closely adheres to the lung, while the parietal pleura lines the parietes. That means parietes means the body wall. And so between the two, there is a potential cavity which is called the pleural cavity. Now, the other features which distinguish the visceral pleura from the parietal pleura are: the visceral pleura is pain insensitive since it is innervated by the autonomic nerves. As against this, the parietal pleura is pain sensitive because it is innervated by the somatic nerves. Now, the visceral pleura develops from the splanchno-pleuric mesoderm, while the parietal pleura develops from the somatopleuric mesoderm. And the blood vessels of the parietal pleura are from the blood vessels of the parietes or the body wall, and the blood vessels of the visceral pleura are from the lung or the blood vessels which supply the lung. Now, coming to the details of the parietal pleura. As I said earlier, it lines the internal part of the thoracic cage or the thoracic wall, and its subdivisions are costal, mediastinal, diaphragmatic and cervical. The costal pleura is the most extensive among subdivisions as it lines the sternum, the ribs, intercostal spaces and vertebral bodies. The mediastinal pleura separates the mediastinal structures which line in the midline from the medial surfaces of the respective lungs. It encloses the structures at the root of the lung, and the dead space inside this ligament allows the expansion of the pulmonary veins. The diaphragmatic pleura covers the superior surface of the diaphragm. It is separated from the inferior surface of the lung by the pleural cavity. Now, the cervical pleura is named so because it extends into the root of the neck. It covers the apex of this respective lung and the cervical pleura is protected in the root of the lung by Simpson's fascia, also called suprapleural membrane. The cervical pleura is related anteriorly to the subclavian vessels. It's very important to know that cervical pleura is in danger of injury during certain procedures at the root of the lung. Now, what are those procedures? It could be the block to the brachial plexus, or it could be an access to the central vein, like for example, access to the subclavian vein. So, when you are inserting a needle or a catheter in the subclavian vein, or when you are injecting into the brachial plexus in the root of the neck, you are likely to puncture the cervical pleura and thereby produce either a pneumothorax or pleural effusion. And this is a serious complication of the procedure because sometimes it can end up into a collapse of the lung. Another important feature or the important relation of the cervical pleura on the left side is it is related to the thoracic duct, which can also be endangered during the procedures at the root of the lung on the left side. Now, coming to the surface marking of the parietal pleura. Now, please understand, students, that surface marking of the parietal pleura is often asked in the examination. You have to answer it in the practical. Similarly, you can get a question on it in the theory also. To understand this, we must know that there are anterior lines of pleural reflection. That means where the costal and the medial sternal pleura become continuous with each other, it is called the anterior line of pleural reflection. Similarly, where the costal pleura becomes a diaphragmatic pleura, it is called the inferior line of pleural reflection. And similarly, there is a posterior line of pleural reflection. So, we will be dealing with the surface marking of these lines of pleural reflection one by one. So, coming to the anterior line of pleural reflection, it begins on both sides at the sternoclavicular joints. So, you start drawing a line just in front on the surface corresponding to the sternoclavicular joints. Now, this line goes downwards until the two lines come close to each other at the midpoint of the sternal angle. Below this, on the right side, the line passes straight downwards up to the 6th costochondral junction, while on the left side, it reaches up to the level of the 4th costal cartilage and then deviates to descend along the margin of the sternum up to the 6th costal cartilage. So, the difference here is not only the deviation of the 4th costal cartilage on the left side, but also the ending of the two lines is different on the two sides. On the right side, it descends up to the xiphisternal joint, while on the left side, it reaches up to the 6th costochondral junction or 6th costal cartilage. Now, coming to the costodiaphragmatic line, on the right side, the costodiaphragmatic line begins at the midpoint of the xiphisternal joint and runs along the 7th costal cartilage. It cuts the 8th rib in the midclavicular line, 10th rib in the midaxillary line, and 12th rib in the scapular line. It ends 2 centimeters lateral to the 12th thoracic spine. On the left side, the costodiaphragmatic line begins at 6th costosternal junction and then passes through the same points as on the right side. Please note that the inferior line extends below the costocyphoid angle on the right side, but not so on the left side. Now, coming to the posterior line of pleural reflection, otherwise also called costovertebral line, it extends from a point 2 centimeter lateral to the 12th thoracic spine and extends upwards to join a point 2 centimeter lateral to the 7th cervical spine. The two lines correspond or are identical to each other on the right side and on the left side. Now, the cervical pleura is represented on the surface of the body by an arched line or curved line, and this begins at the sternoclavicular joint and reaches a point 2.5 centimeters above the medial end of the clavicle and comes down to join the junction of the medial and the middle thirds of the clavicle. Now, we have to know something about the pleural recesses. What are pleural recesses? This is a frequently asked short note question. Now, the The pleural recesses are the extensions of the pleural cavity along the lines of pleural reflections in some locations. In some locations they are present because the pleural cavity is larger than the lung volume in these places. Now there are two recesses, one is called the costomediastinal recess and the other one is called the costodiaphragmatic recess. Now the costomediastinal recesses are present along the costomediastinal lines of pleural reflection, that is along the anterior margins of the lung. The anterior margins of the lungs do not coincide with the mediastinal lines of pleural reflection. These recesses are bounded by the costal and the mediastinal pleurae. The left recess is wider between the fourth and the sixth costal cartilages. Now, except the wide part of the recess on the left side, the rest of the costomediastinal recesses are filled with lung during deep inspiration. Now, the costodiaphragmatic recesses are present along the inferior margins of pleural reflections. Here, the lower margin of the lung falls short of pleura by 2 rib distance. Hence, the costal and the diaphragmatic pleurae come closer to each other, bounding the recesses. Being a very wide recess, they are partially filled with lung during deep inspiration. The costodiaphragmatic recesses are again clinically important. Why? Because they are the most dependent part of the pleural cavity in upright position. And this recess shows widening in an X-ray when there is a small amount of fluid is accumulated in it. Therefore, these recesses are routinely checked whenever a clinician takes a look at this chest X-ray, and these recesses or these areas of the chest X-ray are routinely examined by the physician. Now, coming to the details of the nerve supply and the blood supply of the pleura. The visceral pleura is supplied by the autonomic nerves and bronchial arteries, while the parietal pleura is supplied differently according to the part. The costal pleura is supplied by the intercostal nerves. The peripheral part of the diaphragmatic pleura is supplied by the intercostal nerves, while the central part of the diaphragmatic pleura is supplied by the phrenic nerve. Now, the mediastinal pleura, many a times the student do not know the nerve supply of the mediastinal pleura. Coming to the arterial supply, it is by the intercostal arteries and the internal mammary arteries. Now, another point that is worth understanding as far as the nerve supply of the parietal pleura is concerned, that the lower part of the parietal pleura is supplied by the lower intercostal nerves. When I say lower intercostal nerves, that means 7th, 8th, 9th, 10th and 11th. These are the lower 5 intercostal nerves which supply the pleura lining these spaces. After supplying the pleura and the respective intercostal spaces, these 5 intercostal nerves enter the anterior abdominal wall, and there they supply the skin of the anterior abdominal wall, right up to the lower level below the umbilicus. Now, this has a relevance that if there is an inflammation of the parietal pleura in these spaces, that is spaces, parietal pleura lining the 7th to 11th intercostal spaces, in that case, the pain will be radiated to the anterior abdominal wall. So, even if you have the pathology or inflammation of the pleura in the chest, the pain is felt in the anterior abdominal wall. This is a point which must be understood by every student. Now, we come to the procedure by which a fluid that is accumulated into the pleural cavity. That means fluid could be the pus, it could be water, or it could be blood, or it could be lymph for that matter. So, you want to draw the fluid out, there is a procedure which is called pleural tapping, also called thoracocentesis. Now, whenever it is done, you have to insert a needle into the pleural cavity. So, you insert the needle from the skin and you have to reach the pleural cavity. For that, you have to take certain precautions. You must know that you do not injure the neurovascular bundle which is in the intercostal space. At the same time, you should not puncture the liver or the spleen for that matter. So to do that, a safe point is selected. So the safe point that is selected is in the 6th intercostal or the 5th intercostal space in the mid axillary line or the posterior axillary line, and preferably it is done between the upper rib and the lower rib, more towards the lower rib. And as the needle passes, you have to know what all anatomical structures it is passing to reach the pleural cavity. So you begin with the skin, then you have the superficial fascia and the deep fascia. Then there is a muscle which you encounter in the medial wall of the axilla, that is the serratus anterior muscle. Deeper to it, there is the innermost intercostal muscle, followed by endothoracic fascia, which is followed by the. So after piercing the costal pleura, your tip of the needle has entered the pleural cavity and you start drawing the fluid. If you go beyond that, you are likely to puncture the visceral pleura and the lung. We come to the gross anatomy of the lung. Now, before again going to the gross anatomy, we should know something how a gross anatomy is important to a doctor, to a clinician. For that again we have to look at a case which will stimulate us to learn with interest the gross anatomy of the lung. So there is a case related to the lung now. Let us take a look at it. There is a 60-year-old gentleman who has a history of chronic smoking. He comes to the doctor because he has a persistent cough. Sometimes his sputum is filled or is stained with blood, and he has lost severe weight because of this persistent cough and mild fever also once in a while. Now, when the doctor takes a look at him, he finds on his right eye there is a pinpoint pupil, that means the constricted pupil, and the X-ray of the chest shows an opaque shadow in the apex of the right lung. Now, this patient is subjected to an examination called bronchoscopy, where you insert a bronchoscope through the oral cavity into the larynx and the trachea. And here what the doctor finds is the widening carina of the trachea, and he takes the biopsy of the tracheobronchial lymph nodes, and the histopathological examination of these lymph nodes shows malignant cells. And now you have the picture is very clear, that is malignancy of the lung. So naturally one will ask which area of the lung shows malignancy, and then so on and so forth. Questions can come subsequently once you know that it is the malignancy that is on the apex of the right lung. The lungs are the organs of gaseous exchange. They are located in the corresponding half of the thoracic cavity. They are separated from each other by the structures inside